Okay, so this is just a acute case that was from today, but the patient had this finding for a while, and it's in the liver. And any guesses? Okay, we've got Rajesh saying RPC, recurrent pyogenic cholangitis. Anu says intraductal stone. Perfect. So we can see that there's segmental dilation of the posterior ducts here with all of these filling defects in it on the T2. And on the T1 pre-contrast, these stones were all bright. So can anyone tell me why the stones are T1 bright here? Most stones are not. Rupa says they're pigmented. Perfect. So that's the point of this case. So this patient actually was from Vietnam, and so we think that they had a sort of segmental recurrent pyogenic cholangiohepatitis. They were asymptomatic. They came for a different reason. So we think that this was kind of a remote injury. But when you have intraductal stones, that's rarer than having gallstones, and it's more frequently seen with RPC. And pigmented stones are more frequently seen with RPC. So I just wanted to make a couple of points about types of stones. So gallstones, there's a couple of different compositions. So 90% are either cholesterol stones or they're mixed stones. These will be yellow, yellow-green on pathology, and they'll be the typical ones that are T2 dark and also T1 dark, and we can see them nicely when they're surrounded by bile. This is caused by supersaturation of bile salts, and it's related to having too much cholesterol in your liver, related to diet, obesity, oral contraceptives, different things that will increase your cholesterol. So that's the more common one. And then, 10% are pigmented stones. These are smaller and darker, and they're made of unconjugated bilirubin. So this is a situation, for example, in cirrhosis, hemolysis, or in infections such as RPC caused by different things, which I'll talk about in a second. Why is this important? It's not that important. One thing is that it can lead you to the clue to the diagnosis. So for example, if you see those intraductal stones and they're T1 bright, we know they're pigmented, so it's more likely due to some kind of infection. It also can be important if they're planning to do endoscopic lithotripsy, so they can actually go up this common bile duct and do lithotripsy. Pigmented stones are easier to crush than cholesterol stones. And it used to be important because in the 70s and 80s, they used to do gallstone dissolution therapy, which is basically eating oral bile salts in order to try to get rid of your gallstones, which would work on small cholesterol stones. So now nobody really does gallstone dissolution therapy because it doesn't work that well. Occasionally they'll do this endoscopic lithotripsy, but we can just use it as a clue to know that these might be pigmented stones, and this has a different etiology than cholesterol stones. And then just one word about recurrent pyogenic cholangitis. This predominates in Southeast Asia. It's either from a parasitic or a bacterial infection, leading to portal infection, biliary infection, and then the organisms act as a nidus for the unconjugated bilirubin to form into pigmented stones, and then this leads to strictures. It can also lead to liver fibrosis and then repeated bouts of cholangitis.